Hello, everyone. This is Siddharth Dambar. Welcome to our webinar today. Today, I'm talking about regenerative medicine treatments for arthritis, tendinitis, injuries, and back pain. Well, as we start, just to give you a sense of what to expect, there'll be plenty of time for questions. I will be speaking for about 25, 30 minutes. I'll stop intermittently to take questions. I'll also take questions at the end of this. In addition, if you have additional questions, you can always email us or contact us via the website, and we'll go from there. As we begin, so today's talk is about regenerative medicine treatments. What you'll get from this webinar is the following. You'll learn about the best available non-surgical treatments for arthritis and tendinitis that do not require surgery. So this includes using your own bone marrow stem cells as well as blood platelet treatments. You'll learn about what is legitimate in the field of regenerative medicine and how best to choose a physician or clinic for regenerative medicine as well. Again, that's our clinic's website, chicagoarthritis.com. So the big question, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? What activities with family and friends would you participate in again? So who am I? My name is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, as well as specialist in image-guided musculoskeletal injections. I've been in practice since 2008, involved in regenerative medicine since 2008, as well as in the Regenerative Network since 2012. So my personal journey into regenerative medicine really started with my own shoulder. I used to play tennis when I was in high school. I restarted that as well. During my medical education, I had the privilege of learning about diagnostic musculoskeletal ultrasound at a time when that was still relatively new in this country. And it gave me a three-dimensional view and a different view of how dynamic the musculoskeletal system is in terms of tendons and joints. It got me more interested in tendon and ligament injuries as well. And it made me realize that a lot of the traditional ways that we were treating patients for these issues was really not sufficient. So traditional care for whether you're talking about arthritis, aches and pains, strains and sprains, tendinitis, tendon tears, back pain, neck pain, very much is mask the pain, wait until things get so severe that eventually you need surgery. That is obviously a terrible model of care. Understand that a lot of the traditional treatments that are used prior to surgery, including pain medications, don't really fix the problem, and they have lots of other potential side effects. Traditional injections, such as steroid injections, as well as nerve blocks and radiofrequency ablation, have a lot of issues as well, a lot of side effect potential that are really not good for you long-term. Surgery has a role in more advanced cases, but surgery comes with a higher risk in terms of bleeding, infection, other complications. A lot of traditional surgeries like knee arthroscopy, if you already have arthritis, will actually accelerate the arthritis process, and it does that by causing more instability. More routine surgeries are proven not to, so routine surgeries like arthroscopy in the setting of arthritis has been shown not to be more effective than just physical therapy. And for those of us involved in regenerative medicine, who've been doing this for a while now, a lot of us strongly believe that 80% of musculoskeletal conditions should be able to avoid surgery long-term as well. So in searching for better options, in my own case, my own professional case, really looking for treatments that offer low side effects and low risk, that can improve the actual cause of the problem, which we'll talk about, what's the actual cause of problem for arthritis and tendinitis, and can actually give longer-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process of utilizing your body's own cells to treat arthritis, tendinitis, injuries, and back pain. There's a normal healing process. So for example, if you have a small cut on your finger, you have platelets that first infiltrate the area. They then release, they first stop the bleeding, they then release growth factors. Those growth factors then stimulate your own local stem cells, mesenchymal stem cells, that then creates an inflammatory reaction, which then starts a slow but progressive cellular healing repair process. That works great if you have if you have tissue that has good blood supply. In tissues that have poor blood supply, such as tendon, cartilage, ligaments, other musculoskeletal tissue, or tissue that's been repetitively injured, that method of healing does not tend to work quite as well. So regenerative medicine is the process of utilizing your own cells, injecting them under high-level image guidance to then restart that normal coordinated healing response. So why regenerative medicine? It treats the source of the problem. It's safer than surgery. It's effective for most musculoskeletal conditions as well. So how does regenerative medicine work? It works in multiple ways. Essentially, it helps to optimize damaged cellular health of tissue. So what does that mean? It really means that if you take a look at, let's say, a chronically arthritic joint, you'll find cells, cartilage cells, that are no longer healthy. It means they're not pumping out the right kind of proteins or enzymes that keep a healthy joint. So partly why these treatments work is they get those cells to start working in a more healthy manner, start working biologically in a more healthy manner. In addition, by treating the supportive soft tissue structures, including ligaments, tendons, other soft tissue structures around the joint, we can actually strengthen and stabilize those structures more, which will give you better function and better pain relief. All this will lead to reduced chronic inflammation, improve neuromuscular health, and just generally give you a more stable joint. So what really makes a regenerative medicine expert? And I'll be talking in and out about this throughout the rest of the talk. But number one, your physician should be a musculoskeletal expert. What that means is they should not be dabbling in this. In medicine, there is no dabbling that leads to expertise or real wisdom long term. So if your physician is, treating somebody's age management issues on one hand, then treating their blood pressure in the next room, and then coming to your room and treating your knee, that's not the right way to do it. You should be focused just on the musculoskeletal things. Number two, they should be a non-surgical musculoskeletal expert. My surgeon colleagues are very good at surgery. They don't have the same kind of experience when it comes to these kind of treatments. In addition, they don't have the same kind of experience when it comes to the image guidance required for these kind of treatments. So because of that, you really want someone who's focused on how to treat this non-surgically with the best tools available. They should be using image guidance for all procedures. I have older colleagues who don't believe in using image guidance. They feel like they can just, by palpation of the skin, they can figure out where to go. That may work for steroid injections, but when you're injecting your own cells, you have to be very pinpoint and exact to where you're placing the cells. Otherwise, this won't work. They should understand how to use inflammation to help you heal. There's a difference between chronic inflammation, which is problematic, versus acute inflammation, which is normal. They should understand the different types of biologic treatments that are used, including blood platelets, as well as bone marrow stem cells. They should be able to give you a very personalized treatment plan versus a one-size-fits-all. I'll give some examples of that in a moment. They should understand the concept of prolotherapy and how to treat instability. They should be transparent regarding potential results and candidacy for treatment. They should follow your results long-term. It should not just be they do a procedure and don't ever see you again. And because these treatments are still new, they should be able to guide you through the process. That means you should be able to ask questions, and they should be able to tell you why they're using what they're using and how to compare that to other traditional treatments. So in terms of other basics, questions that I hear all the time, is this legal? Simple answer is yes, there are strict guidelines from the FDA, and as long as we follow those guidelines, you are within a legal framework. Another question I get is, if I'm older, should I use someone else's cells? The simple answer is no. For most orthopedic conditions, there's good medical evidence that using your own living cells is effective. There's a couple of exceptions. I'll talk about that in a bit, but using your own cells is the way to go. Is there an age limit? For the most part, no. For knees, lower back, shoulders, elbows, ankles, and neck, these are not impacted by age. Hip outcomes, however, can be worse if you're older than the age of 65. So what sort of doctor does these treatments? Again, I recommend that your physician should be focused on musculoskeletal conditions. They should be focused on non-surgical treatments for orthopedic conditions, and they should be a proper regenerative medicine expert. So can these treatments help if you've already had surgery? Yes, if you've had like an arthroscopy surgery, However, if the joint's been totally replaced, we should not be injecting into that joint, and we cannot really reverse that. My general rules for patients with orthopedic surgery is try to keep your own anatomy, avoid surgeries that are just cutting out tissue, and always consider a regenerative medicine treatment option if you have been recommended surgery. Okay, so some very key regenerative medicine concepts: stability and prolotherapy, orthobiologics, and interventional orthopedics, and I'll talk about each one of these. Stability is so key when it comes to the body, in particular your musculoskeletal system. There's this concept in architecture called tensegrity. Essentially means that when you take a individual unit that are weak on their own, if you put them in close approximation and compress them, they are stronger as a whole than they are as individual units. So in biology, that is called biotensegrity. Prolotherapy is the idea of injecting your own cells into soft tissue, supportive structures, to strengthen them and to stabilize them. The keys here are that when you have a problem, let's say at a joint level, your problem is not just at the joint, it's at all the layers before that. And so you want to treat all those layers in depth. And the reason why is because as you strengthen each one of those supportive layers, you will get a progressive strengthening over time, which will lead to longer lasting results for you as well, as opposed to only treating that one structure that is problematic deeper in. So case study, this will 71-year-old man with lower back pain. He's had surgery in the past. So when we talk about treating all the different layers, we're treating, in this case, the ligaments, the facet joints, the muscles, and the epidural space. That's every layer of tissue that's involved. Initially, we treated him with his own blood platelets. He had mild improvement. We then escalated several months later to utilizing his own bone marrow stem cells. He's now at a much better improvement and doing well longer term now. Orthobiologics. These are the cells and tissues that we inject into damaged orthopedic tissue. Again, this utilizes your own normal body's healing process. And again, I strongly recommend you use your own cells versus someone else's. In the United States, that is the only thing that is legal, by the way. So platelets are really the first line orthobiologic treatment. After an injury, platelets recruit other cells. We talked about this, and they help to start the normal healing process through inflammation. Those growth factors from the platelets help to stimulate your local stem cells. So there's different types of platelet preps that we can make. And this is important because you need to have nuance and subtlety to create a treatment approach that is correct for your specific problem. If your physician is taking a one-size-fits-all approach, by that I mean if you have knee arthritis versus lower back pain versus rotator cuff tendinitis, and they're making the same platelet preparation, that's not the right way to do it. Some issues require a very high concentration of platelets, some require moderate concentration, some require what's called platelet lysate, which is where we just take the growth factors from the platelets, because that's better for the nerves and ligaments. So there's a lot of nuance here. And if you don't have a flexible lab approach, which most physicians are not using with this kind of treatment, you don't have that kind of bespoke and specific personalized approach. The picture on the right is an example of this. There's red blood, so there's platelets on the right and the left. The ones on the right are platelets that still have your red blood cells, and the ones on the left are where we've taken out the red blood cells and all you have are your platelets and plasma. So important, because if you're injecting into a joint, I wouldn't recommend the one with the red blood cells. I'd recommend the one without the red blood cells. It's less inflammatory. The ones with the red blood cells can be better and more appropriate for muscle issues, but the ones on the left are going to be better for joints and tendons. So your physician has to have the nuance and sophistication to be able to do that. And if they don't, then the problem is that you're not really going to get the right and ideal kind of outcome. So this is a case study of a patient that was referred to me for knee tendinitis, 45-year-old man, cyclist, originally came with left knee pain, referred by a sports medicine doc. On his imaging, he has patellar tendinitis on MRI as well as on ultrasound. So this is an example of treating patellar tendinitis under ultrasound guidance with a high concentration of his own platelet. So this picture on the right, this is the kneecap. This tissue is the tendon. That's the needle. This is obviously a zoomed in picture. The needle is really not that big, but this is a zoomed in picture under ultrasound. He had two treatments with for his patellar tendinitis and was able to get back to full activities. I saw him 3 years later, at which time now we had his other leg. Now we had a hamstring issue. Again, we treated him with PRP and again, pain resolved and back to activity. Great example of how you pick the right treatment for the individual and he can have a great response. Also, a great example of how repeat treatment can sometimes be useful and how if a person has another issue, you can also treat that as well. So the next type of orthobiologic to be aware of are your stem cells. These are the main cell that drives tissue repair and recovery after an injury. Use your own cells, 100% use your own cells. In the United States, the only type of living stem cell treatment that is legally allowed are coming from your own bone marrow. You can use fat cells for structural support, but the enzyme that you need to help release the stem cells is considered illegal to be utilized in humans in the United States. You may have also heard about amniotic and umbilical cord cells. In the United States, there are no living cells in those products. In other countries, depending on how these cells are prepped, there may be living cells, there may be some theoretical issues with injecting somebody else's cells into you. I would be careful. If you can use your own cells, always better, safer, more proven. Almost all the data out there is in using your own cells. IV stem cells, there's no proven benefit for orthopedic conditions. I do know a lot of people who are getting that done in other countries now, but again, there's really essentially no data out there, research data, medically proven data that says that's appropriate. So stem cell treatment outcomes, yes, we can actually improve pain and function, even if you have advanced cases. Can we improve how your X-ray and MRI images look? If you have advanced arthritis, not necessarily. If you have a tendon tear or ligament tear that's still relatively small, yes, we could make the images look normal. If you have bone swelling in an arthritic joint, we can make that look normal. I'll show examples of that. If you have a condition called avascular necrosis, which is where the bone is starting to die, we can get the images to look better, not just improving your pain. So other common questions, can we treat bone-on-bone arthritis? It's a really terrible term, bone-on-bone arthritis, that a lot of doctors use. And the reason why is because arthritis is not just a picture on an X-ray. It's not just a structural thing, it's a biologic condition. Classic thing that I see is that you see a patient who's had X-rays of their knees, one knee has pain, one knee doesn't, and yet the level of arthritis is the same in both. Or a patient with severe arthritis on X-rays on the knees, and yet they can fully bend their knees. And so there's more to it than just what your X-rays or MRIs look. This is a biologic condition, and so the orthobiologic treatments that we use can still work. In particular, if your range of motion and function are still intact, good outcomes are still possible. There are caveats to this. If you have advanced arthritis and you in the hip, then generally expectations are much lower. Then you really should be considering replacement at that point. But with that said, I'll show you some examples where imaging gets dramatically better, but still our primary endpoint goal is improving your pain, improving your function, and improving overall quality of life. So can tendon and ligament tears be treated? It's a great example of a patient who had a knee ACL injury where we show that that can happen. So if you have a partial thickness tear, definitely we can treat those. If you have a full thickness tear, some of these can. If you have a full thickness tear where the ends of the ligaments and tendons are still relatively close, we can still treat that. If it's fully torn apart, then you should get surgery. Mind you, if you get surgery, you should still consider getting your own bone marrow cells injected into that afterwards. That may actually help to prevent a repeat tear later on. So this is an example case of a 28-year-old man who had an ACL tear. This is a regular guy. This is not a high-level athlete. He was playing recreational volleyball. He's actually a butcher by trade. So I saw him relatively soon after his injury, at which time we did a bone marrow stem cell treatment. And within 3 months, he's doing great in terms of pain relief. He's restarting more dynamic exercise activity. And amazingly is actually how his imaging looks. So the picture on the right is his procedure image. First arrow, that's his kneecap. That's his thigh bone. That's his shin bone. This is the needle. And this is the ACL, what's lit up. So how do you inject a deep structure like this? You cannot do this blindly, meaning just feeling the skin. You have to do this under high-level X-ray guidance. You can't even do this under ultrasound. So here's his MRI images, which are just absolutely fabulous. So his pre-treatment MRI on the left. Again, kneecap, sorry. Thigh bone, shin bone, here's the ACL right here. Now, what you'll notice is this is very hazy and difficult to see. Very poorly visualized. His radiologist has described this as likely a full thickness tear. Now, the picture on the right is his MRI 3 months later. Again, kneecap, thigh bone, shin bone. Now here's his ACL. Now you see a structure that's very clearly outlined, very linear. And this is not only a great clinical result in terms of pain relief and functional improvement, it's a phenomenal result in terms of MRI as well. And so the goals in this individual's case are not only how do we keep him functioning at this level, at a high level right now, but can we actually maintain this and actually prevent him from developing early onset arthritis, which would typically happen with an ACL injury. An example of a rotator cuff case. It's under ultrasound. So this is a 57-year-old man. He's a contractor. He's had shoulder pain for quite a few years with overhead activity. His ultrasound, this is his pre-treatment ultrasound on the left side. That's the bone. That's the tendon, bone, tendon on the picture on the lower left. This hole here, that is where his rotator cuff tear. This is a full thickness tear. That's a pretty significant tear, actually. So we ended up doing a bone marrow stem cell treatment protocol in his case, and the ultrasound on the right. So he's not only doing clinically great immediately after treatment. This is his ultrasound on the right side. Again, tendon, and where you saw a big hole in previously, now you have tissue that's essentially replaced that now. So he's doing not only great from a clinical standpoint, returning to work, returning to activity, he's doing great even from an imaging standpoint. So lastly, interventional orthopedics. This is the medical practice of using image guidance to treat orthopedic injuries. That means using ultrasound and high-level X-ray guidance. So here's some nice shoulder examples of that on cases that we've done in the clinic. So picture on the left, this is his rotator cuff tendon, the supraspinatus tendon. This tiny little hole right here, this is his tendon tear, and that's a needle. Again, this is a really zoomed up version here. So that tear that we're looking at, that is 1 centimeter by 1 centimeter, very tiny. That's not something that you can really be injecting blindly. That would be really trying to find a needle in a haystack. Picture on the right, this is an X-ray image. Here we're treating somebody's shoulder joint as well as slap tear, labral tear. So here's a glenoid, here's the humerus, here's the needle. How do we know we're in the joint? Well, we see a tiny little bit of contrast before we inject cells. So we make sure we're exactly there. And this little triangular structure up here, that's actually his labrum. So how do we know we're hitting the labrum? Well, we placed correctly under ultrasound guidance. I'm sorry, in this case, X-ray guidance. And we then confirm it under fluoroscopy. And that's what that looks like. So that's a nice example of how we're very particular in terms of where we're placing the needles. So we talked about some knee imaging before. The one on the left was a patellar tendon. The one on the right is a knee ACL. Again, these are things that, if done appropriately with the right technique and image guidance, these are those are the kind of outcomes you can get. Great outcomes. This is a ankle case. It's a man who had early arthritis and avascular necrosis. He is a chef, and so is literally standing on his feet for 10 to 13 hours per day. So he's developed avascular necrosis, which essentially means death in the bone. So the picture on the left, this is his ankle joint, and that's the bone. You see that lighting up. He ended up doing the 3-step stem cell protocol. 3 months later, symptomatically doing great. 3 years later, still doing great. His imaging 3 months later is pretty exciting. And the reason why is because what you saw before, the avascular necrosis, has essentially disappeared. It's been treated by injecting his own cells into that area. and just doing absolutely wonderfully, which is exactly what we want to see. So regenerative medicine treatments offer safe and effective solutions for your pain. I have a few more slides to read. Please keep on submitting your questions as they come in. And if you want to learn more about what we're doing, please go to chicagoarthritis.com. Common questions I get, number one, is this too good to be true? So great question. And yeah, I've been doing this since 2008. And so while we say this is a new field, the reality is that it's been around for a couple decades now. Philip Hernigue, French surgeon, orthopedic surgeon, has been doing this since the mid-1990s. The Regenerative Network, there's data that goes back to 2005. This is rapidly developing, this field, but it's not new. There's definitely right and wrong ways to do this. Your expectations should be grounded in reality, evidence-based medicine. Some of my orthopedic colleagues who 10 years ago said they didn't think these treatments could be helpful, now they'll say they think it could be helpful, but they're not sure. The reality is that the data that we have now for the last 15 years plus is such that there's certain conditions that these kind of treatments should be your first line options rather than steroid injection. Meaning if you fail conservative treatment like rest and activity modification, physical therapy, and if you're still having knee pain, lower back pain, elbow tendinitis, shoulder tendinitis, this is the right next treatment option rather than jumping to a steroid injection or surgery. So how long do results last? Again, Regenerative has data that goes over 15 years. Philip Hernigue has data that goes over 20 years. I still tell people think conservatively. By that, I mean, if you have a chronic condition, you've had knee pain for 5 to 10 years, expect that a repeat treatment at some point, a few years after initial treatment, will be needed. That could be either just a platelet booster treatment. It could be a bone marrow stem cell treatment. The best way to maintain results after treatment would be improve your biomechanics, take the appropriate supplements, maintain ideal body weight and metabolic health, and then repeat cell-based treatment is additive to that initial treatment. So in terms of cost, understand these are not routinely covered by insurance. The exceptions would be if your company has added the Regenerative corporate plan to their benefits plan. If you want to learn more about that, please go to regenerativcorporate.com. However, otherwise, the typical cost estimates that you can find in the United States would be PRP starts at $2,500 and bone marrow stem cells start at $8,500. Again, I recommend the keys to determine value are, number one, is your physician and the clinic regenerative medicine experts? Are you receiving a real stem cell treatment or something that's been mislabeled? And also understand that these are in-office procedures, so you can typically avoid hospital and surgery center fees. So we talked previously about what makes a musculoskeletal or regenerative medicine expert. Again, I think these are the key ones. They need to be a musculoskeletal expert, non-surgical expert. They need to be an image guidance expert. They need to understand how to use inflammation. They need to know how the different biologic treatments work and how to tailor it specifically to you. They need to understand prolotherapy and instability. They should be able to give you a very transparent sense of your candidacy and results to expect. They should be able to follow your results long-term, and they should be able to guide you through the process. There's some questions coming through. Let me just catch up on some of those. Good question. Somebody asked, how often do you need to do the PRP treatments? There's not a one-size-fits-all treatment. I've seen some clinics where they'll do exactly this number at every single patient. And in my experience, that's not correct. In my experience, you should treat somebody on day one and then give their body a chance to recover and heal and see how you're doing 2-3 months later, sometimes even up to 6 months later. And if you're still doing better, still trending upwards, then you continue to follow. On the other hand, if you are flatlined and you're not at your goal, then I would recommend repeating treatment at that point. So it just depends on the person. Okay, somebody else asking about hip arthritis, bone on bone, so is a full replacement. I think the way to think about hips, again, hips are an exception to what we do. And by that, I mean that if you have hip arthritis that's advanced, and if you have reduced range of motion, like if you can no longer move your hip inwards, then yes, you should be considering hip replacement at that point. You still have range of motion that's normal in the hip, then you may still be a candidate. But it's really going to depend on some additional things like age as well as your MRI imaging. Okay, somebody asking about knee osteoarthritis. How soon would you see improvement? Again, there's a little bit of difference from person to person, but what we normally tell people is post-treatment, you'll have inflammation for the first 2-3 days. That means pain and swelling. You'll then get back to baseline over the next week. You'll have stiffness for the first week or two. You should be noticing improvement at roughly the 3 to 4 week mark. And then if you're using platelets, getting better for the next 3 to 6 months. If you're using your own bone marrow stem cells and getting better for the next 6 to 12 months. So these treatments are longer lasting. They also have a slower ramp up. So next question, somebody asking about arthroscopic removal of bone fragments from arthritis. Cleaning up of the joint twice for the last 2 years. Now I'm being told I need knee replacements. Can you realistically help? Yes, absolutely. So number one, unfortunately, what you're describing, if it's arthroscopy for the knee, the clean out surgeries, unfortunately, the data for the last 20 years really convincingly shows that the clean out arthroscopy surgeries for knees are no better than physical therapy on its own, and actually no better than even sham surgery, where they just pretend to do surgery. They've actually done studies where they compare someone who had a full-on surgery versus folks where they just put an incision and didn't do surgery. And they found that there's no difference in terms of pain relief at the 1 and 2 year mark. So very common that we still see patients who've had knee arthroscopy if they've already had knee arthritis. The problem is that it makes the knee more unstable. And the classic description, which is what you're describing, is that you've had a clean out surgery a couple of times, and now 3 to 5 years later, now you're being recommended knee replacement. That is very classic. I would not recommend that. And the reason why is that what we know about knees is that even in advanced knee arthritis, the chance of getting an average improvement, which is 65%, is at the 1 and 2 year mark, is still very good. So I would say still consider one of these treatments before jumping to surgery. Somebody asking about they tore their ACL 30 years ago. Will this treatment still work so many years later? Yeah, I mean, the way to think about that is you've had an injury in the knee in the past. You probably have had chronic instability. And so what we need to do is essentially treat not only the joint where you may be having pain, but also treat any of the other instability areas, whether it's the ACL or the other ligaments. I would not expect the ACL to get back to normal if you had your injury 30 years ago. The key is if we treat it 30 years ago, right? But if you want pain relief, functional improvement, a more stable knee, then yeah, absolutely, that can still be treated. Okay, somebody asking about how many shots are involved in treatment. Depends on what your issue is. Again, there is no one size fits all process. There is a process where we look at what is your problem, and then we treat all the areas that need to be treated. By the way, somebody asked about the cost. You can look on the screen again. We talked about that a few minutes ago. But let's say you have knee arthritis. In general, you have to treat the knee joint and the cartilage. You need to treat probably the knee meniscus. You need to treat the ligaments as well. It depends on which ligaments. Is it just the MCL, or are we treating multiple other ligaments? So that could be anywhere from 5 to 10 areas that need to be treated in that one person. On the other hand, let's say you have patellar tendinitis, right? Where you don't actually have arthritis in the knee yet, but you've got tendinitis in the knee. Well, now we're treating the tendon in 1 or 2 spots, maybe treating other ligaments as well. It may be anywhere from 2 to 4 different spots that we're treating. So it really depends on what area needs to be treated and what your issue is. Okay, somebody asking about arthritis in both hips. They just receive shockwave therapy. Again, depends on exactly what your issue is. How bad is the arthritis? Is your pain really coming from the hip joint? Is it coming from the soft tissue around the hip? Is it coming from the SI joint in the back of the hip? Is it coming from the lower back? It really depends on a lot of other things. If you have primary hip arthritis, then if we're using bone marrow, I'd recommend focusing on the one hip and then treating the other hip several months later. If your hip arthritis is very mild, and let's say you have also a lower back issue, and we may be using platelets to treat that, we'd probably be using platelets to treat the lower back, and then we could treat both hips at the same time. So it really depends on your specific issue as well as what needs to be treated. It's good questions. So just a little bit more about how we work here at Chicago Arthritis and Regenerative Medicine. So, we are focused on non-surgical treatment for your arthritis, tendinitis, injuries, and back pain. An evaluation that focuses on inflammation, instability, asymmetry, and neuromuscular issues, correcting with low-risk interventions if possible, and if not, then escalating, if appropriate, to a regenerative medicine treatment, utilizing the best available treatment options. That means your own cell plan that's specifically designed for your condition, and injecting those cells under the highest level image guidance to make sure we give you the best chance of a good outcome. How to get evaluated? Simplest way, you go to chicagoarthritis.com. You can contact us either through email, or you can actually go to the website and just schedule an appointment directly with us. In the chat section, you'll also see our email address as well as phone number to contact us if interested, as well as our website address. Okay. Great. Somebody asking about cost. No. The cost is for that is on a per treatment basis. So if in one knee you have to treat 5 different spots, you're not getting charged 5 times the price. You're getting charged for just treating that whole area. So it's just one cost, and then we decide on which areas to treat after that. Okay, somebody that looks like you've tried to contact us. Sorry, never got a response. Please send us an email to admin@chicagoarthritis.com. Perhaps this has gone to spam, but we'll make sure to look out for your name, ma'am, and we'll make sure to contact you appropriately. Wonderful. Any other questions at this time? Okay, if not, I will go ahead and shut down our webinar. I appreciate everybody's time today. I hope this was helpful and educational. If you want to get in contact with us, you got all our contact information. So in the chat section, you can see our actual email address, but it's admin@chicagoarthritis.com. And if you have any other questions, please feel free to call, email us at any time. We're here to educate as well as be helpful in any way possible. And until we connect again in the future, I hope everyone has a good day and lives well. Thank you very much. Bye-bye.